ways. And it's hard to think about HIV when we're thinking so much about COVID, but for some of us, it hasn't been. But it is good to keep our eye on the HIV pandemic as well as the COVID pandemic. This is a educational activity that we put together starting a few years ago, and I think it was one of the first that really started to think about HIV through the prism of the Southern experience, and things in the South are different. And you just have to go out of the South and talk to folks about what they're doing and what their states are doing and their cities are doing, and it's a different world, as we'll talk about. So I think some things are the same everywhere, and some things are pretty particular. In fact, I find that as I travel, back when I traveled, there were more things in common sometimes that I saw in Africa with HIV management and where we are here in the South compared to what I see up in places like Boston and New York and San Francisco. So we have some challenges, and so trying to understand that is key to managing our patients. We take it for granted that this is just the way it is. There's the usual accreditation type stuff and disclosures that we're typically seeing in these presentations. And I think you guys know, we now all know Zoom etiquette. So I'm just going to go over a little bit of COVID-y type stuff and then get into HIV, and really the COVID stuff relates to HIV. So this is evolving, and you can't even keep this slide deck up to date. I'll just kind of verbally tell you what we know right now about COVID and HIV. And I'll tell you that the good news is there's really not compelling data to suggest that people living with HIV are more susceptible to infection with the SARS-CoV-2 virus. It gets a little bit more murky when we start talking about, are people living with HIV more at risk for severe disease? So it's confusing because the data are not fantastic. As far as susceptibility, when you look at hospitalization data and even some other reports, it does look like people living with HIV might be getting diagnosed more than others, disproportionately, depending upon how you look at that. But I think a lot of that is explained by who people are. And many people living with HIV are folks who are essential workers, people of color, people who live in neighborhoods where there's more COVID-19 transmission. There's been some really nice analyses just over the last couple of weeks showing, using cell phone data from almost 100 million people, modeling where people could potentially be interacting with each other. And folks who live in neighborhoods or census blocks with lower socioeconomic status, meaning more poverty, there's more points of interest. There's more places where people huddle, whether it be a store or a church or a workplace, than in more affluent areas. And so there's just more places where it's exposure is more likely. And so that really would overlap nicely, unfortunately, with where COVID was surging. So I don't think that just being HIV positive makes you more susceptible. I think living with HIV and being a person with HIV in our country is a marker for other factors that may lead you to be more exposed to the virus. And then data regarding hospitalization are also tricky. There's some really interesting data from the UK that shows people who are admitted for COVID-19 tend to be much younger if they're HIV positive than people admitted who don't have HIV with COVID-19. But part of that might be that providers are more likely to admit somebody to the hospital who has HIV infection because they're worried about them as having an underlying condition. That may or may not be part of it. It's a little confusing, but it could explain some of it. Certainly, I would be worried about people with lower CD4 cell counts. Those folks may have less immunity, and that may be a problem, but I don't know for sure, and we don't have really great data. So we just have to find out a little bit more about this as time goes on. But right now, no huge signals. That everyone says, well, immunocompromised, but there's lots of different types of immunocompromise, and I'm not sure that we know enough about this. And even in some of the early plans for who's going to get vaccinated, HIV is not on the list of things that qualify you as being immunocompromised enough to get vaccine among the first round of vaccines for COVID-19 that will come out. So right now, don't know that it's really any worse for people living with HIV. There certainly are some cofactors that I think complicate this. And we do know that there's more opportunities for people living with HIV to acquire the virus, and that they don't seem to do much worse than anyone else, given their other risk factors for severe disease. So I think that's really important. There's been talk, and patients sometimes ask about whether or not their HIV medicines protect them against SARS-CoV-2. The answer is no, it doesn't. There's really no data at all to suggest HIV medicines, even if they work in the test tube, work to protect people or treat people once they are infected. We did try to give Kaletra, lopinavir, ritonavir because of some lab data. I gave this to a bunch of people early in the pandemic. It doesn't work. We then did studies that found that there was no difference in improvement in people who got the Kaletra versus controls. So this is another good example of why science is really important. So there's no evidence. I wouldn't change anyone's HIV therapy. People have looked at tenofovir because, again, in the test tube, it seems to do something, but there's really no data at all to suggest that we should do anything different with our HIV therapies. There is really good guidance about making sure we take better care of our patients when we're stretched. Right now, our telephone visits, our video visits are sort of like a tether that keeps people at a distance but connected. It's really been a challenge, and I suspect that if anyone's doing a good job of it, it's you guys. But I can tell you here at Chapel Hill, it's been really a challenge making sure people get their medicines refilled, making sure that they're doing well, and getting their blood work done. This has all been really a big problem. So how do we counsel people? We tell them, we're sorry, but you're going to have to be a little bit of a squeaky wheel, is what I'm trying to tell some of my folks. Chat me, send me texts, call the clinic if you're in trouble, if something's running out. Those are really important. We're trying to do things like provide 90-day supply of medicines when we can instead of 30 days, getting people into commercial labs or our lab just at the hospital or our outpoints to just get blood work done without coming in for a physical visit, just trying to be creative. And really, for some of the people who've been doing well for a really long time, and it's now 8 months since their last visit, maybe extending it out to a year for those who it could be done for. So just being sort of flexible as we think about things and how to reopen, especially now that we're going through another surge. We do know that for PrEP, this has been pretty devastating, and most of the data we're seeing shows that starts of PrEP have gone down significantly, and that many people have stopped PrEP, mostly because they're not feeling that they're at risk right now, but I think also just because they're not having the access. And there's been a number of different studies from all parts of the country showing that PrEP utilization is down, and STI screening has gone down as well. I do think that that's going to be an issue. And I'm also worried about clean syringe programs that are really been suspended or truncated, so that I'm worried about a resurgence in some of the STIs, including HIV and also hepatitis C and HIV in people who inject drugs, just because I think some of the effective prevention measures are just not in place right now. So again, we're trying to be creative and have people come in for screening when they can, but I think this is complicated, especially as the situation gets worse. So I'm going to stop there because I just would be really interested, and I know it's hard with the Zoom, but how are you all dealing with providing HIV care and HIV prevention with COVID, and like specifically what you're doing now, like over the last few weeks, seeing people in person, doing phone visits, telemedicine, getting people just to come in for labs? How are you guys handling this?
Well, from March to August, we were strictly doing telemed. Since then, we've transitioned back into the clinic, and I would say probably 95% of our patients are coming back into the clinic. We only do a few a month telemed. I'm trying to think. We still provide transportation. but we only transport one patient in at a time.
Right.
Prior to, COVID, we were doing 2 to 3 people. So it's decreased the amount of patients that we see during the day. And with our PrEP, we do have a PrEP clinic, but we haven't been getting as many referrals as we had in the past. So it's kind of, unfortunately, just been at a standstill for the last probably few months or so.
Yeah. Interesting. That's really helpful. So I think you're opening safely than a lot of other places. We see people in our clinic in Chapel Hill, but it's much fewer than normal. A lot of telemedicine.
We do have the patients a high no-show rate lately. I think Dr. Lewis and I were talking that, the patients, if they're doing well, they're not, interested in coming in and having lab work or coming to their appointments. They just want their prescription refilled and,
Yeah, absolutely. So questions that you have or that your patients ask you about COVID, anything about HIV and COVID that you want to bring up or questions about or discuss? You don't have to.
I think that you covered most. This is Michael Lewis. I think you covered most of what our patients have asked about. Are there special precautions they need? Can they get excuses not to go to work because of COVID? And
right.
For the most part, the CDC has agreed with what you said. There's no reason for them to take any extraordinary precautions than the rest of us.
Yeah, I think, for my patients, I tell them that I understand their concern. I don't think that their HIV puts them at risk, but maybe their obesity or their diabetes or their hypertension or their age puts them at risk. And that's what I care most about. On the other hand, I don't think we could ignore the psychological and mental health impacts of, surviving one pandemic and dealing with it. And then, having to deal with this on top of it. And I think a lot of our patients are isolated already. And so I think the biggest thing for me is just really attending to the mental health aspects of being HIV positive and now being isolated. And again, HIV being a marker for depression, for food insecurity, stigmatization, and all those things that you know a lot about. Awesome. This is good. I'm going to talk now more generally about HIV and not so much within the context of COVID, although it's hard not to think about COVID when we're talking about cases like this one. This is Bernadette. She's a woman who's treatment experienced and talking about switching. So she's 27 and she lives in the South and she presents for a routine follow-up, if you imagine. She asked if she could be on one pill a day. And her background is she was perinatally infected. Her CD4 cell count now is great and her viral load undetectable for many years. She's on a boosted PI plus TDF-FTC. She has a number of mutations that are known because of her long-term history and running around and someone trying to squirt medicine in her mouth when she was a kid. So she has a 184 against the FTC. She has a 103 against the efavirenz she was on in the past, and a 70 that probably reflects some AZT along the line. She gave birth to twins a year ago, and now she's status post-tubal ligation. This is a case I wrote based upon 90% of this story is basically true, but she lives in North Carolina. So she gave birth to twins a year ago, now status post-tubal ligation. She's got hypertension, not just gestational, and she's on 2 blood pressure medicines. She's busy. She works full time. She's never been a smoker. She has supportive partner and family. So she comes in and she's doing great. Her blood pressure is never perfect. Her BMI is 30. She's awake and alert. Her labs look pretty decent. And so she wants to switch because she's now on, 2 medicines that she wants to know if she can be on one of those 1 pill a day type things. So any concerns? And one of the things I want to highlight is certainly her resistance mutations, but also her BMI. And the reason for that is that, we'll talk about what kind of medicines there are available that she could take that's 1 pill a day, but most of them are integrase inhibitor based. And integrase inhibitors like dolutegravir and bictegravir Like, they've changed everything for us. They're easy to take. There's hardly any side effects. They're really potent. And if you screw it up, it's very hard to get resistance to those two integrase. So they've really made treating HIV easier and better in many ways. But obesity, we're going to talk about, does seem to be a problem, or weight gain, with those two particular integrase inhibitors. So that's Tivicay and also the medicine in bictegravir. So we know in the South is where we see more obesity. Obesity has now become much bigger problem across the country, of course. And I think the COVID-19 pandemic has really revealed just how big a deal this is, right? Because we know that obesity does spell higher risk of severe COVID-19. And then when we start looking at people across the United States who have obesity, real obesity, a BMI over 30, and super obesity, extreme obesity over 35 BMI, it's not a small proportion. So that means a lot of folks are at risk for severe COVID. But when you start looking at people of color in regionally and obesity and extreme obesity, it's even more so. So it's more than half the country, but especially here in the South. And we know over time that the levels of obesity and severe obesity are really increasing. So this is not something that is plateaued. It's something that's going up, such that almost half the folks in the country are either obese or have severe obesity. And so for people living with HIV, this is definitely operative as well. And we used to think in the olden days about HIV being associated with anorexia and cachexia and lipoatrophy, but it's really obesity that's the predominant issue related to body morphology that we're dealing with, as you know, for people living with HIV. And so the places where we see most obesity and the places where we see HIV overlap, so that's not too surprising. And so when we think about switching medicines, we could look at the single tablet options, and here I tried to indicate which classes these different pills include. And as again, you'll see most of them are integrase based, that's the top half. Then when you start getting down below, you're talking about NNRTIs, like rilpivirine or doravirine. And then there is a single tablet of darunavir, cobicistat, which is a PI. So there's some options. So we can talk to Bernadette and say, well, here's what we're thinking, and try to whittle down from this list what we think might make sense. I would tell you that most people are going to gravitate towards a single tablet with an integrase, and that makes a lot of sense, but we definitely have to be a little careful about that. And that's because of data like this, where people who switch to an integrase inhibitor experience this weight gain. So either when they initiate therapy or switch, and it seems more profound, if you will, for non-white females. So females of color, we're seeing greater weight gain than we would for white females. And even among non-Black men, at least in many of the studies, there's more weight gain than white men. So, but certainly all the data overlap that for African women and for African-American Black women, we are seeing greater gains when switching to an integrase or starting an integrase compared to other people. The study that really helped us a lot in understanding this, and this is a big caveat, this is done in Africa. So this is not saying necessarily this is what's happening here, but I do think that there's some parallels that we should just keep in mind. But here's a pretty clean way to look at it. So if you took 1,000 people, men and women, and this is done in South Africa, so everyone was African, Black African, and randomize them to start HIV therapy with efavirenz TDF-FTC, so a tripla, versus dolutegravir and TDF-FTC, or dolutegravir plus TAF-FTC, so the newer version of tenofovir, and randomize them equally, 350 people in each, and follow them. All three therapies worked. They worked to get the virus down, T-cell count was great, really just a slam dunk. This works really well in this setting. But the problem was that the weight that people gained was very different depending upon what therapy they were assigned randomly. And so you could see for women on the left and men on the right, there was this gradation where people who got in the blue, which is the efavirenz arm, they gained weight. I mean, that's what happens when people start HIV therapy, they gain weight. In fact, that's what happens to most people, even without HIV. Over time, we gain about a kilo, believe it or not, about a pound or two a year. But when you look at this, you can see there's this gradation where the people who got the dolutegravir, they definitely had more weight gain, and people who are on TDF, more than efavirenz. But if you had TAF, TAF was much more. And now we're talking about a lot of weight. So if you're talking about 8 kilos, now we're pushing 20 pounds on average in these women. Men, it was less, it was about half, but they still had this gradation. And so when you start looking at treatment emergent obesity, so moving from not obese to obese, 26% of the women had treatment emergent obesity after 7% of the men. So there's clearly something going on. What's going on is unclear exactly, though, as far as the mechanism. It's clear that there's a gradation, that there's one regimen here that's worse than the others. But one of the theories is that maybe TDF prevents you from gaining weight, that it causes a little bit of anorexia, and that TAF really is inert. But it doesn't really matter if you're on this regimen versus this regimen versus this regimen. This is the kind of weight that many folks are gaining. Other studies have found the same sort of thing with bictegravir. This is a nice analysis of a whole bunch of clinical trials. So whatever I think we're saying for dolutegravir, we would say for bictegravir. Elvitegravir is an older integrase inhibitor. It doesn't seem to cause as much weight gain. And again, these types of studies also showing this difference based upon sex and also based upon race. So I think there's a consistent message here. Why this is, we don't know. There's a whole bunch of factors that may play into this about drug metabolism and other types of things that are associated with genes, and genes and race are not overlapping completely, but there's some predilection that we can talk about that I think maybe explains some of this, but we're not really clear why this happens. So again, back to her, she has this, already borderline obesity BMI. Are we concerned about switching to an integrase TAF-based regimen given upon what we just saw? And I would say, yeah, we are. And we would have to certainly talk to her about it. And I would counsel her that this is one of the things that if we did start an integrase, that we would have to think about along with other things. And there may be an alternative, and we can talk about an alternative and the trade-offs for that. The TAF issue, again, this is complicated. I don't know if TAF is contributing to weight gain or TDF just helps you not gain weight. We moved a lot from TDF to TAF, mostly because TAF has better bone and renal profile. And so I think we've kind of bought in, most of us, to TAF, but you're going to experience more weight regardless of whether or not TAF makes you gain weight or TDF prevents you from gaining weight. And the best data we have from this really to think about is what about PrEP studies where we have people not HIV infected, so there's no return to health, and what happened to them when they got TAF versus TDF, and there was more weight gain with TAF. And again, that doesn't mean it was TAF making people gain weight, it just meant that maybe TDF was preventing people from gaining weight. But regardless, it doesn't matter the reason, you're going to experience more weight gain on TAF than you are going to on TDF. So other things to think about with her is, does this work? And if she said, well, I want something that, you could tell me is going to work. And do you have data? If you're going to switch me, show me that there's data to, that proves that switching me to whatever you're going to switch me is going to be effective. People ask all the time, okay, I want to switch to a single tablet, but will it work? And so we can reassure her there's some data. And here's data on BF-TAF, Biktarvy again. And this is, again, what I think a lot of people would switch to. In African Americans here in the United States, switching from medicines just like what she's on, who've been suppressed for a long time and doing great on their medicine, not too surprising that switching to another effective regimen would work just as well as staying on your medicine. So we have some data. Interestingly, in her case, she has this 184, and we're all taught, oh, you should use 3 active drugs against the virus. Turns out that if you have the right 2 active drugs, you don't need 3 active drugs. And so this is what's interesting about this data set. And I'll show you that there's other data too, that even though she might have resistance to one of the 3 medicines in Biktarvy, the FTC, and the same thing could be said for Tivicay plus Descovy, even if you have that FTC not working, the other 2 can carry the weight. And we've seen a bunch of studies that show this. So even in this study, it's not a lot of people, who we knew had this 184, where we know one of the medicines in started Biktarvy is not going to work very well. The other two did great, and 100% of people were able to get suppressed. So I'm not too bothered by this 184 when we have something like a tenofovir type of drug plus an integrase. That doesn't bother me. And there's other data, this is data from Africa again, but this is people who are failing a regimen, who are put on dolutegravir plus 2 nukes that were predicted to work versus Kaletra plus 2 nukes. And I won't talk too much about the study, but I think it's really important that the integrase inhibitor worked better than the protease inhibitor, but really amazingly, even in people with the 184. So this is the real big thing. Regardless of this 184, people on the integrase inhibitor, dolutegravir plus 2 nukes, one of which may not be working very well, did just fine. So she switches to BF TAF because, I drank the Kool-Aid on it. I know maybe she'll have weight gain, maybe she won't. It's not 100%. And she gains 10 pounds. And so I have egg on my face. I warned her about it. She says, "Doc, it happened. What are we going to do about it? I don't want to have this extra weight." And so we don't know what to do about it. We can think about, well, what if we switch her? So what would we switch her to? We don't have any data. So there is a switch study that's kind of interesting in that people are switched to dolutegravir 3TC. So get rid of the TAF, and maybe that makes a difference. It didn't. People who switched from a TAF-based regimen to dolutegravir 3TC, unfortunately didn't lose any weight. They seem to have a very stable weight. So we don't really have anything that we can offer, although we do know that there's some medicines that if you look when people start, they don't gain that much weight. Now we don't have as much data on these as we do for some of the integrase inhibitors, but a medicine like doravirine might be something that I might switch her to. Or maybe that's what I should have switched her to begin with when she wanted a single tablet. Unfortunately, doravirine only comes packaged in a single tablet with TDF, the older version of tenofovir. So that may not have been the most ideal situation for her. So it's a tough one. I think that we made the right choice given the data we had. Given she's got a 184, I would have been reluctant to just put her on dolutegravir 3TC, and it probably wouldn't have changed, the weight issue. So weight problems are thorny, and I do think that we're running into some of our patients who probably our medicines have made them gain weight. When we see this, though, I really think it's an important point. This is not like I've been gaining weight, over the years, and then you switched me and I'm still gaining weight. This is I switched and then I saw my weight go up, much like we see with when we start antidepressants or people stop smoking. So I'm going to stop there again and just get sort of your points. Like, have you seen weight gain? Is this a big concern for your patients? And I'm not just talking about weight gain in general. I'm talking about like HIV therapy related weight gain and how you've been tackling that if you are seeing that.
We've had patients that have complained of weight gain, and sometimes it's hard to say whether during this COVID time is inactivity, poor eating habits also contribute to it, but there's definitely information that these cause it. I was wondering, in her case, since she had been suppressed, couldn't she take a drug like Juluca, and that would be a choice since she had been suppressed for such a long time, and that way she would not have been on the TAF. She would have avoided that. And it seems like from my reading, the combination of integrase inhibitors plus TAF seems to be worse than either by themselves.
Yeah, so I think that's a good point. So I think that Juluca, which would be this dolutegravir rilpivirine, that could be an option for her, even though she has the K103N, a Fabryon's mutation, rilpivirine and doravirine would work. I would be a little worried about the dolutegravir. You're right, it is worse. And when we look at something like this may help us. So here's the TDF dolutegravir arm. So if it's something like this, maybe a little higher, it's still not great. I think dolutegravir really is associated with this weight gain and probably what's driving it. So I'd be worried about this. This is a tough one. She could take, if we wanted, Odefsey, which is TAF, FTC, rilpivirine. I would be a little worried about that with that 184. This also has to be taken with food. So there, you're trying to avoid something that is going to make people gain weight, and you have to take it with food. So this is troublesome. I think this is a really tough issue. And that's why I brought it up. I don't know. And also you can try different things and see what they do. I mean, to be really honest, the combination that's most likely not to make her gain weight would be this: doravirine, 3-TC-TDF. We use TDF all the time in the past. Most of our patients don't get bone or kidney problem. So I have to be honest, if she gained 10 pounds on Biktarvy, I might be tempted to do this. It's not something I do very often. I would do it if in a younger, she's 27 years old. She has good kidney function, although she has hypertension. So this again might be something that I would think about. You're right, though, the TAF may be, or the absence of TDF may be the issue. And dolutegravir rilpivirine may be a good thing to try and just see. Other thoughts? Other people dealing with it? And of course, we always tell, the story I hear is, ever since you switched me, I think I've been gaining weight and my diet hasn't changed and my exercise level hasn't changed. Again, with COVID, everything's changed, but that's the story I sometimes hear.
For gaining weight, I mean, with the TAF and the integrase saver, it seems to be more pre-diabetic than it'd be cardiovascular.
That's right. That's right. So far, I think in the short run, when they looked at it in that advanced study in South Africa and looking at some of the cohorts in Europe, it looks like that this weight gain isn't immediately leading to cardiovascular outcomes. And that makes sense. That takes a while, but we can start to see some glucose intolerance and even diabetes develop as people gain weight. So I think this is unfortunately one of the downsides of the newer integrase. Again, it doesn't happen in everyone. I think it's reversible. I don't think it's irreversible that if you're on Biktarvy or you're on Tivicay that you're going to gain weight and it's never going to go away. I think it does, but it does limit this to some extent for some folks. And so I do worry about this in some of our folks, especially women, and counsel them. And I've been tracking weight very carefully in my patients just because I'm worried that we might miss this and it might be, insidious over time. When I do start to see it, I ask people to be careful about their caloric intake. And then if it gets worse, change things. One thing I didn't mention is that it does seem that maybe raltegravir and elvitegravir have less of this. I don't like elvitegravir because of the cobicistat. I don't use boosters. I try to keep people off of medicines that will raise their lipids or boost other medicines unintentionally. Some people have had success with switching people to raltegravir, another integrase inhibitor. It doesn't have as high barrier to resistance, but seems to have less weight gain. So that's another thing I think worth trying. But again, we don't have great data. There's going to be a study starting up in January. It was supposed to start up, of course, months ago, looking at people who gained weight on an integrase and switching them to doravirine and seeing if that makes a difference. So we'll hopefully have more data over time. Sorry. I have one more case that I was going to talk about and get your thoughts about. So this is a 31-year-old man. He was called by the health department because he's a contact of somebody diagnosed with early syphilis. He says he feels fine. He's a smoker. He has some ADD. He works as a manager in a factory. He's a man who has sex with men. He has 1 to 2 partners per month. He's versatile as far as top and bottom. He doesn't use condoms all the time, and he had sex last 2 weeks ago. On exam, he's afebrile. Everything, his vitals look good. No lesions, no rashes, no lymphadenopathy. His RPR is 1 to 64. His antibody antigen combo test is negative, and he has 3-point testing for STIs, and he has gonorrhea in his throat. So, we talk to him and we say, hey, you might be a really good candidate for PrEP, and we'll treat your STI, of course, STIs, but, is he a good PrEP candidate? So I think so. He might be. He's afebrile. He has no rashes, lesions, or lymphadenopathy in his recent test for HIV, looks like he's negative, and he says he didn't have sex in the last 2 weeks, so he's almost probably certainly HIV negative, so he might be a good candidate for a start of PrEP. And so I think this is important because we miss this opportunity often, and even in people like him who we offer this to, some of the data we're seeing, including in places where they're really, I think, PrEP conscious, we see this, this cascade, which we're used to for HIV care, but also for PrEP, where in this one particular analysis of a lot of people, only half the people who actually were linked to PrEP care got on PrEP and stayed on PrEP. So we know that there's a lot of folks who just aren't interested, or people who don't initiate it, or people who initiate it and don't keep up with PrEP. And that's partly because it's a pill a day. And we also know that over time, even in people who start to take it, they stop, and that those people who stop, they start to increase their risk for HIV. So the probability of remaining HIV negative starts to go down as people start coming off of PrEP. And so this is a big issue for a lot of us in thinking about this and trying to cut down on new cases. Again, we know where HIV is on a county by county level, and it's the darker counties here. And we know that there's relatively huge gaps in uptake in PrEP between the burden of HIV in an area and the uptake of PrEP. And this has a lot to do with a lot of different things, including perceptions. And this is a study that was done among PCPs in the South in high prevalence areas for HIV. And there were a lot of misconceptions. There's over 500 primary care providers about PrEP, about HIV, about risk, and about who's getting infected. So I think part of this is explaining why outside of centers like yours and ours, we don't see as much PrEP use. And this is a really great of the people who would be more likely to provide PrEP. And in the South here, and an area that's rural versus urban, with greater than 5 diagnosed cases of HIV. So where there's some HIV, and the dots really are in the urban areas, and in the darker non-urban areas where there's HIV, you just don't see providers. So there's this desert, if you will, of PrEP providers where they're needed as well. But I think if Antonio came in and he didn't have this, but his HIV and his numbers are acceptable, and his HIV testing is negative, and he looks great, we don't think. Then we get to this question, which I think is somewhat inside baseball, about TDF versus TAF. Again, we talked about the weight gain, that maybe there's more weight gain with TAF versus TDF. He's not overweight. He's not at risk for that. So I don't think that would really determine anything for me. Data we have from the Discover trial of people who are men who are sex with men or transgender women shows that both worked really well. This is a huge study of thousands and thousands of people, and there was only a handful of infections. TAF seemed to be more favorable than TDF as far as reducing infection rate, but it wasn't statistically different, numerically different. So I think both work. I don't think there's anything wrong with it. Recently, just not that long ago, we saw a study, huge study of injectable cabotegravir. So this is an injectable integrase inhibitor given to MSM and transgender women, and then more recently women, cisgender women. And it worked better than TDF-FTC. So there were more infections, 5 to 10 times more infections in the TDF-FTC arm than the every 8-week injectable cabotegravir arm. Hopefully we'll have cabotegravir injectable coming to us within the next year. That would be fantastic. And then that might offer another option to people instead of having to take a pill every day for those who think they would do better on every 8-week injections. And we could talk about that during the discussion. So, but what if he was positive? That's a whole nother issue. So, here now he comes in, and let's say he was a little febrile and, didn't have any of this, but his recent HIV testing was positive, and it looks like he had a confirmed antibody, so it's not acute HIV. should we rapidly start HIV therapy? And it'd be interesting to hear what you guys would do if someone came in, syphilis contact, you get an antigen antibody test, it's positive, and then you confirm he has antibody, would you start him on HIV therapy like right away? And rapid means different things to different people. In San Francisco, it means I'm going to go to the back closet and pull out some HIV medicines and hand it to you. In my clinic, rapid means I put in a prescription to the specialty pharmacy and they mail it to you in 3 days, which I think is pretty rapid. But different people have different definitions. This is really it's a small study, but it's one of the only studies in the United States that I think motivates me a little bit to think that rapid start is worth all the effort. And by that, I mean, if you look at this cohort, this is in New Orleans, these are newly diagnosed people, and starting HIV therapy within 3 days of the diagnosis. And so the first dose of ART was directly observed during the visit. Within the first 3 days of the diagnosis, people come in, they're given a dose, they're given a 30-day supply, and they get their laboratories checked then, right? Like, not waiting for the laboratories to come back. They're enrolled in insurance as they need to be. And a lot of these folks were young, and that's really key. And some were young, but not as young. This is mostly male, but not only. Largely people of color, but not only, and mostly MSM. And what they found, which was really interesting, is even in the young people who are the hardest group, and again, not a huge number, but virologic suppression was really good, and it was quick, and it was sustained after 12 months in a large proportion of those, including the younger people, and engagement in care was very high. And so I think this is really reassuring. If we see this in larger numbers of people, I think it would be even better. But it does maybe play into this. If you start HIV therapy in sort of an urgent manner, it seems to maybe kind of cement a deal where people theoretically take it seriously, are more engaged in care, and more connected to it. And again, we've seen this in other parts of the world, seem to be retained into care better. So again, I don't know that, doing this all is hard work. You have to have access to medicines in a pharmacy, give it to people right away. And some of us do have that and some of us don't. But I do think that this kind of plays into this narrative that maybe starting early is better. So a few different things there. One is just thinking about PrEP, and certainly how we're doing PrEP, and maybe an injectable PrEP will be something that some of our patients, just like injectable HIV therapy, might accept. And then the other thing is just thinking about rapid HIV therapy and how rapid is rapid and what you guys are doing.
I think we're pretty inconsistent. I think we have samples and we started to say we're going to do rapid therapy. And I do think rapid therapy is beneficial, because even before they have a decrease in their viral load, I think there's a sense of well-being when people are taking ARTs. And I think if you start to feel better even before the lab comes back, you're more likely to continue taking the medication. I think we do it on some and we don't do it on others, and I can't explain. Some of it we don't make the diagnosis. The diagnosis is made before we see the patient, so therefore we don't have the opportunity to make the early start. We start them when we see them, but that diagnosis may have been 2 or 3 weeks ago before we see them. I do have a question about the long-acting PrEP, and the question I have is, how are you going to pick patients? I understand the drug has extremely long half-life, and it's recommended that you give it every 2 weeks, every 8 weeks.
Mm-hmm.
If someone makes it to 10 or 12 weeks before they get a shot, is there a chance of resistance? It doesn't seem to have the same barrier to resistance that the other integrase inhibitors have.
Right. So yeah, so the nightmare scenario is somebody is due for their every 8-week shot, and now it's past 8 weeks. Now we're getting, to 10 weeks, 11 weeks, and then they have an exposure and they get infected, and the virus is now replicating while that drug level is going down. That is a real concern. So in the big trial that was just presented over the summer among men who have sex with men and transgender women, there were about 12 infections that occurred in people who got the cabotegravir, and 5 of those were people who seemed to be on schedule for their shot, and the others had been off of their shot for a while. And we don't have any resistance data from that study yet. I think that's going to answer the question for us better about whether or not there's enough selective pressure, as you pointed out, from this integrase, that once someone acquires HIV, that they're going to have integrase resistance. And if they do, what kind of integrase resistance is that going to mess up starting HIV therapy? So it's a big unknown. I think that's a major concern. I can say that we do know for TDF-FTC, right, that people who take PrEP with oral therapy and then stop and then start back on it, not knowing that they were infected during their lapse, we do see resistance as well. That generally is 184. We don't see tenofovir resistance, but we do see 184 a bunch of times. So there's some risk of that even happening with TDF-FTC or TAF-FTC, but I agree that could be a big downside for the injectable if we're seeing that happens a lot. The good news is out of 2,500 people, there was only a dozen infections in a clinical trial in the injectable arm, but if you're going to then get exposed, that could be a problem.
So David, I have another question about PrEP. So we've had our PrEP clinic here probably about 2 years, and right now we have 46 patients. So with your patients who are HIV positive, what's the percentage of their partners who are on PrEP? Because right now we have, let's say 400 active patients. To me, in a perfect world, we should have 400 patients, on PrEP. But it's just that
Really?
it's
maybe, I don't know. I mean, if you have 400 patients living with HIV and 385 of them are undetectable, do you really feel compelled to have their partners on PrEP? Right?
Not if it's a truly monogamous relationship.
Right. Depends who your partners are. So, right. But if they're right, so I think we have this conversation all the time with our folks, and so if you're undetectable, the hard part I have for some of my patients is convincing them that they really are not able to transmit their virus to other people because they're undetectable or hardly able. They just don't believe it. So, but then I have other folks, of course, who have multiple partners. So. Or their partners have multiple partners. So I have many of my patients who I say, well, are you monogamous? Yes. Is your partner monogamous? Not so much. That partner should be on PrEP. So,
do you think that having points of care for HIV patients is probably the wrong place to start PrEP? It should be in the primary care doctor's office who sees the STDs, who sees the chlamydia, the gonorrhea. That's where the PrEP should start. And I think what we do is we see the patients that are HIV positive and we ask about their partner, but we don't always see the person that came in with chlamydia. They're taken care of by their family doctor. And I think some of the emphasis has been placed on places of care to take care of HIV patients to be the main place to start out this PrEP, when it probably should be in the primary care doctor's office.
Yeah, absolutely. It's got to be primary care. That's where we're seeing it. And, I think before COVID, I think there were some really good strides, as you all know, trying to get more primary care. I think the company did a pretty good job of reaching out to family practice and general medicine people. It's been on the uptick. Certainly more and more people have been getting PrEP. I think the problem with PrEP is just this whole 1 pill a day thing. And we have to have more options. That's why I think people don't take it, or if they do start it, they don't keep up with it. And intermittent PrEP, 2 pills before, 2 to 24 hours before sex, and then a pill the next day, and then a pill the day after that. It's a big thing in France. We don't do it as much. It works pretty well. I just don't, people don't seem that excited about it here as much. And I think it's a little cumbersome. We just need a better PrEP. And I think the injection is one way, but I think we're going to need other things. And there are. The good news is there are other therapies that are being developed, including a once every 6 month injection and even a once a week pill. So I just think we need more options.
I think we give our patient the option, but I think I agree with you. If you see somebody that's non-detectable, I present PrEP to them. I really don't present it forcibly if they say they're in a monogamous relationship and they're undetectable. I present it and say, this is the option for your partner, but I'm not as forceful in those patients.
Yeah. I mean, and here's a scenario. So here's one that we've had in the past. The guy is HIV positive. The woman is not. They want to have a baby. So we talk about it, and I say, well, look, he is undetectable. He's been undetectable forever. He takes his medicines. He's adherent. Here's the risks. It's pretty darn low. We could put you to her on PrEP, and maybe it's belt and suspenders, maybe it's not, and make a grown-up decision about it. And some women say yes, and some women say no.
On the long-acting PrEP, they included more women in the study then, so we'll have a better idea of whether we can use this on women also, right?
So there were 2 studies, which is great. So one study was done on men and transgender women, and another study was done of 3,000 women, was done just on cisgender women. And that's the one that just came out the other day in a press release. And again, I don't remember the numbers off the top of my head, like 36 infections and 4 were in the cabotegravir IM arm. So really, and the others were all in the Truvada arm. So yeah, so we have a lot of data on women now with that study. So I think it's going to be there. We'll first get the injectable HIV treatment. That's going to probably come first quarter of next year. So that would be IM, cabotegravir, and rilpivirine, which again, that might have been another option for our first lady, Bernadette. We don't have a tremendous amount of data on cabotegravir and weight. Some of what we've seen shows there might be some weight gain with it, but again, hard to tease that out from just normal weight gain. We don't have comparative studies, but that if it does pan out that there's less weight gain with cabotegravir, that might be something to offer people. But that's another big question for the injectable, is how much weight gain we're going to see in the right populations. That's
how long will you do the lead in for oral to the IM? How long will you?
Yeah. So right now for oral, in the treatment studies and in the PrEP studies, you take oral medicine first, just to make sure you can tolerate. You don't want to inject something that lasts a long time in your system that you have a reaction to, although that so far has been extremely rare. So I think in the future, we may see shorter periods of oral or even just injectable. But for treatment, as long as 16 weeks has been used, but I think we're going to see it come out. It'll be interesting to see what the FDA approves. I think it's going to be much shorter. I think once they look at all the data from the different studies, I think we're only going to see a few weeks that people have to be on oral therapy. Remember, it's so important for everyone to know, injectable cabotegravir and rilpivirine for HIV treatment is only given to people who are suppressed. So you have to get them suppressed first. So it's always a switch. Even if someone comes in newly diagnosed, they get on oral therapy first, and then if they haven't been on the cabotegravir or rilpivirine, oral therapy to expose them to it, and then start the IM. So there's a whole bunch of different ways to slice this. You could start someone on more conventional therapy, add on. So if you started someone, you could use oral Biktarvy and get them suppressed, and then add on cabotegravir and rilpivirine, short period of time, make sure they tolerate it, and then switch to the IM. So there's going to be a bunch of different ways to do this, but it's going to be at least 4 weeks of a lead-in. So not as easy as it sounds when you just think about injectable medicine. And talk about transportation. I mean, so that, and remember, it's going to come out for treatment every month, not every 8 weeks at first. And that, although that may change, we'll see. It may, given the delay, it was supposed to be available earlier this year, even before COVID hit. There were some problems with the FDA approval of the manufacturing process. It had nothing to do with safety. There was just some problems that the company had in their manufacturing that the FDA didn't like. So they had to rectify that. That delayed them, and then COVID hit. So it may be that they will be able to open up every 8 weeks, which would be much easier. I think a lot of people would do better on every 8 weeks than every 4 weeks for treatment as well.
Now, this is not a simple IM injection, is it? I mean, it's a special technique IM injection that we'll have to train the nursing staff how to give, right?
Yeah, not too hard. It's the gluteus medius. So that's sort of the side. It's not all the way in the back of the butt. It's more on the side of the butt. And that gets you away from the sciatic nerve. But yeah, you have to get it in the right place. The company is working hard on videos and sending people to train y'all and doing us too. We have some experts here because we've been doing the studies. Some people use the Z technique, right? Where you pull, introduce, pull the other way, introduce, so that you're kind of making a Z path instead of a straight line. And I could tell you the injection site reactions, everyone has some reaction. It's pretty short term. It's nothing like IM penicillin. People say they're a little sore for a couple of days. Very few people who are motivated to be in these studies, very few people end up stopping because of the injection site reaction. So we'll see. I think that's going to be like the big next thing, like how we're going to deal with it. Our clinic is totally not set up for this. I think it's going to be a little complicated, just like everything else. So we're going to have to really think hard. I have a feeling we'll be learning from your example, because I think you guys think about things a little bit more efficiently than we do. But yeah, I think IM is going to be interesting. We have 2,000 people in our clinic. Even if 10% of them are candidates for that, that's 200 people that we have to figure out how to get IM to. But most of it will be switch. So I think that, you know, people who are switching, it's exposing them to some cabotegravir and rilpivirine for 4 weeks and then switching them. So that's a little bit easier than starting afresh and getting someone suppressed for a few months and then switching to IM. All right, I want to be mindful of your time. You guys have been great. So yeah, it's perfect. Other questions or anything that we didn't talk about that you wanted to bring up? Well, thanks. This has been great. I appreciate it. And it's always good to talk to you all, and great to hear that you're hanging in there and seeing your patients and doing all the hard work you're doing, which is fantastic.
Thank you, Dr. Wolf.
Thank you. All right.
Thank you, Dr. Wohl, and thank you all for joining. Lisa, if you just wanted to fill out the registration form and get that information over, you'll all get an email from me with post-program information. Just take a minute to fill it out, and you can claim a certificate of completion as well. So thank you all again, and thank you, Dr. Wohl, and you guys take care.
Thanks. Have a good Thanksgiving.
As well.
Bye.